Good morning, friends. Today we'll be starting with diabetes mellitus and pregnancy. So what happens is diabetes, it is a chronic metabolic disorder due to either insulin deficiency that can be relative or absolute, or due to peripheral tissue resistance to insulin. Okay, the ultimate effect is your hyperglycemia. Then we come to the glycosuria in pregnancy. It is seen in 5 to 50% cases. This is a normal phenomenon. What happens is that whenever we take random urine samples during pregnancy, the renal threshold decreases. And why it decreases? Due to increased GFR and impaired tubular reabsorption of glucose. Therefore, glucose leaks out into the urine, even though the blood level is below 180 milligram per deciliter. So when urine is examined, we can detect glucose in it, but it is not an alarming situation. It is a physiological process, and therefore urine is not used to measure the level of glucose in patient of diabetes because it is unreliable. There is no treatment required, and this condition disappears after the delivery. Okay, so glycosuria, when it can be suspicious. So if it before 20th week or on 2 or more occasions, if it is positive, then we have to do glucose tolerance test, which is the screening as well as the diagnostic test. We can also do this when we have positive family history for diabetes or a past baby that is macrosomic, more than 4 kg. Okay, then we have our Ogtt test. This is the screening test and diagnostic test. You have to do it before 20th week and between 20th to 28th week. If it is positive, okay, we'll see the values. If it is positive before 20th weeks, it is the overt diabetes or the diabetes that is present before pregnancy. Okay, and if it is present during 24 to 28 weeks after, so it is the gestational diabetes. If fasting blood glucose level is more than 95, or ingestion of 75 gram, 2 hour Ogtt test is done, and the glucose levels are more than 126, then we say the person is diabetic. And which type of diabetes it is? It is gestational diabetes. So gestational diabetes is defined as carbohydrate intolerance of variable severity with onset of first recognition during the present pregnancy. So it is detected during the present pregnancy, and it has occurred due to the present pregnancy. If it was present earlier and detected now, it still counts as overt diabetes. Pregnancy induced glucose tolerance is a more appropriate term. Okay, it usually presents in the late second or the third trimester, because during this time the insulin resistance is maximum in the body. Okay, so it comes back to normal within 6 weeks of delivery post in the puerperal. Potential candidates that can have gestational diabetes are one which have positive family history, which have previous history of stillbirth, which have unexplained perinatal losses history, which have polyhydramnios history or recurrent vaginal candidiasis in the present pregnancy, persistent glycosuria more than 30 years, and obesity. So these are the values you should remember. So if it is more than 126, it is a gestational diabetes mellitus. If it is more than 200, this is again your overt diabetes mellitus. Okay, and these both are OGTT, matlab after 2 hours. So this screening should be done to all pregnant women. So the method is employed that will take 75 gram oral glucose without any regard that what was the last time of the meal, okay, between 24 to 28 weeks of pregnancy. So we don't care if the patient is nil per oral or had meal previously. So what are the hazards of diabetes? Increased perinatal losses is associated with fasting hyperglycemia. Fetal anomalies are not increased. What happens in gestational diabetes mellitus, that the first trimester has been surpassed, and in first trimester organogenesis occur. So in gestational diabetes mellitus there is no reason for gross congenital anomalies, but in overt diabetes mellitus we have gross congenital anomaly risk because it occurs during the first trimester itself, because the disease is present from the very beginning. Increased incidence of macrosomia, polyhydramnios, birth trauma, and recurrence increases in 50% of the pregnancies. Patient needs more frequent antenatal supervision. So we have to make sure that her fasting plasma level should be less than 95 dl. So how will do? We use the diet, exercise with and without insulin. If it is your gestational diabetes mellitus, first you go on diet modification. If it doesn't work, then we go to insulin. But if it is our over diabetes mellitus, we always have to give insulin, no matter what. Okay. So what happens is, when should we start human insulin in gestational diabetes mellitus? When even after diet control for 2 weeks, the postprandial value is more than 120 milligram per deciliter, even on diet control of 2 weeks. So we still continue, then we go for insulin therapy. Okay. Then obstetric management. So good hypoglycemic control. She might not require insulin and she may wait for spontaneous onset of labor, but we have to do so. We have to make sure that the pregnancy does not crosses 40 weeks. So around 38 weeks we make sure that the delivery occurs. Okay, we can do it, induce it, we can go for elective delivery like cesarean or induction. Okay, so nearly 50% of the women with GDM, gestational diabetes mellitus, will develop over diabetes mellitus, and they can have cardiovascular complications as well. So patients with symptoms of diabetes mellitus, polyuria, polydipsia, weight loss, and random plasma glucose concentration of more than 200 milligram is considered over diabetes, that we have already discussed. So it means it is existing diabetes that has been first time diagnosed during the present pregnancy. So again, fasting glucose is more than 126, and 2 hour post glucose level is more than 200. If it 2 hour more post glucose have more than 126, then it would have been gestational diabetes mellitus. I am again repeating. Then vasculopathy, it is important predictor of the outcome. If the patient has poor glycemic control and vasculopathy, that the child is at risk for intrauterine death, intrauterine growth retardation, preeclampsia, and ketoacidosis. What are the effects of pregnancy on diabetes? So what happens is, whenever there is a pregnancy, we have human placental lactogen, estrogen, progesterone, free cortisol, and there's degradation of insulin by the placenta. So this all antagonizes the insulin. So the glucose leaks out into the urine. So we have urinary glycosuria. So it is not used to estimate level of glucose because it is unreliable. Then we have a concept that is known as accelerated starvation. There is rapid activation of lipolysis, so there will be ketoacidosis, and there will be increase in hyperemesis, meaning there will be increased vomiting and nausea in the early pregnancy. Infection will increase like vaginal candidiasis, and there will be fasting of labor. Labor will be induced early. So it should be iatrogenically induced by beta sympathomimetics and corticosteroids for the management of preterm labor. Insulin requirement falls significantly in puerperium, that we have also discussed. Vascular changes can lead to retinopathy, nephropathy, coronary artery disease, neuropathy. Any kind of pathy can be occurring. Then we have effect of diabetes on pregnancy, the other way around. So during pregnancy you can have abortion, you can have preterm labor, and why? Because of infection and polyhydramnios. You can have urinary tract infection and vulvovaginitis. Increased incidence of preeclampsia, polyhydramnios. So what happens? Why there will be polyhydramnios? Large baby, large placenta. Fetal hyperglycemia will lead to polyuria. So more the polyuria, more is your amniotic fluid, and it can also lead to maternal distress. Again, it is destroying the mother's body by diabetic retinopathy, diabetic nephropathy, and ketoacidosis. During labor, there is increase in the duration of labor, prolonged labor due to the big baby. Shoulder dystocia will be occur, that will read in the other video. Okay, and we can have perineal injuries, we can have postpartum hemorrhage, and we can have operative interference. Fetal macrosomia. Okay, what happens is when we have maternal hyperglycemia, hypertrophy and hyperplasia of fetal islets of Langerhans, they increase the secretions of fetal insulin. Because there is maternal hyperglycemia, there will be hyperglycemia in the fetus also, so it will release insulin. So this insulin, it acts like growth factor and increases fetal growth and adiposity. Also maternal free fatty acids are increased, it causes adiposity, and where it is actually deposited in the shoulders and the abdomen region. Therefore shoulder dystocia is common. 30 to 40% people have fetal macrosomia. Then congenital malformations occur, but it only occurs in overt, because overt diabetes occur in first trimester, leading to organogenesis. And what is the pathology? Free oxygen radicals are formed. So how do we detect early fetal malformation anomalies? So we'll go for HB1AC. More the level of HB1AC, more are the chances of fetal malformation. How we'll see? Before 14 weeks of pregnancy, we'll estimate HB1AC. So we'll see what is the control over previous 3 months. Okay, so before the 14 weeks of pregnancy, if we do the HB1AC, we'll see what is the 3-month control. We can also see, this is important, then we can also see maternal fetal alpha fetoprotein. We can go for ultrasound examination. This is known as TIFA scan. This is targeted imaging for fetal anomaly scan. This is important, done either 20 to 22 weeks. Birth injuries can occur. Why? Due to prolonged labor, shoulder dystocia. Growth restriction can also occur, and it is due to vasculopathy. Okay, fetal death can occur, and why this occurs? Due to hypoxia and lactic acidemia. Now we have some questions. First is these are some gross congenital anomalies. So most common congenital anomaly in a child will be cardiovascular, and then will be neural tube defects. Then what is the most specific gross congenital anomaly in a child? That is caudal regression syndrome and sacroiliogenesis. VSD is the most common cardiovascular anomaly. Transposition of great vessel is the most common anomaly also, and we can also have HOCM. This is the finding. Hypertrophic cardiomyopathy. We can have renal agenesis, hydronephrosis. We can have single umbilical artery as well. So fetal complications, what can we have? We can have hypoglycemia, that is less than 35 milligram per deciliter. Respiratory distress syndrome. Why it will occur? Because what happens is that the insulin, it decreases the synthesis of corticosteroids. So if more the hyperglycemia, more the insulin is released, less will be the corticosteroids and less will be the surfactant, and there will be respiratory distress syndrome. We can have hyperbilirubinemia and polycythemia. Together they cause hyperviscosity of blood. We have hypocalcemia, hypomagnesemia, and hypokalemia. We have cardiomyopathy. Long-term effects of this can be childhood obesity, neurophysiological effects, and diabetes. Perinatal mortality is increased 2 to 3 times, and it is principally due to hypoglycemia, respiratory distress syndrome, polycythemia, and jaundice. These 4 things are important during the care of the baby to manage them. Then how do we manage it? With preconception counseling. Women are taught about self-glucose monitoring, and appropriate advice about diet and insulin is given. When we have antenatal care, so it should be done monthly up to 20 weeks, and afterwards 2 weeks interval it should be repeated. Okay, the patient should be admitted for the stabilization of glucose and for monitoring the fetus. Ideal plasma glucose should be, fasting should be less than 95. Okay, 1 hour should be less than 140, 2 hours should be less than 120, and HbA1c should be less than 6. Sorry for the delay. Okay, so we have already discussed urine is not valuable to us because it is doubtful. 6 is the desirable. Then we will do sonographic evaluation, TIFA scan. Okay, and assessment is made during 28 week onwards. We will do biophysical profile and NST every week, and we'll do Doppler umbilical artery velocimetry in case of any vasculopathy. Insulin therapy, so you cannot control it with diet. If you cannot control with diet, you have to give insulin. Okay, and the goal should be less than 95, the fasting glucose level. As the pregnancy advances, we use a double mixed regime. What is double mixed regime? We give 2 type of insulin. First is the regular insulin, and first is the intermediate acting insulin. We give regular insulin and during the meals, and intermediate acting insulin before the bedtime. Okay, so they are given. So the main purpose is to that there should not be any harm to the fetus while there is no hypoglycemia. This is also known as mixed ARB insulin. Generally, oral glycemic agents are contraindicated in pregnancy, glycemic drugs, but we can give metformin if the lady is not accepting the insulin. Induction of labor at the 38 weeks. If the woman has vascular complications like preeclampsia, IUGR, after 37 weeks you have to induce. Methods: no breakfast or morning dose of insulin, low rupture of membrane, epidural anesthesia for pain relief, and if the labor does not start within 6 to 8, then the cesarean should be performed. And when is the cesarean performed? Whenever the size of baby is more than 4.5 kg for a non-diabetic female and more than 5 kg for a diabetic female. Cesarean section, it is done when the lady is elderly, primary gravida, she has bad obstetric history and is a multigravida, diabetes with the complications or difficult to control, complications like preeclampsia, polyhydramnios, malpresentation, and fetal anomalies, that macrosomia, that we have already discussed. Then places of awaiting spontaneous labor. So it is only done when the gravida is primary and she is young and her obstetric history is good, or her diabetes is well controlled, or there are no complications, because it is risky to wait till EDD. So should not be overrun the expected date. The combination of fetal hyperglycemia and anorexia not only contributes to fetal distress but also responsible for your respiratory distress syndrome. So we should not allow labor for more than 6 hours as we read above, and low rupture of membrane should be done, and if that is not possible we go for cesarean section. Okay, the cord should be clamped immediately because we don't want hypervolemia. Already the blood is viscous. Shoulder dystocia might be a problem. Placenta is large, cord is thick, and there are increased chances of single umbilical artery. Therefore, placenta and cord should be inspected on delivery. Management of acidosis. Degree of acidosis should be assessed. Arterial blood gas should be assessed. Blood glucose, ketones, electrolytes. So insulin from 0.2 to 0.4 units per kg as a loading dose to 2 to 10 units per hour as a maintenance dose. Isotonic NaCl 4 to 6 liter in first 12 hours and 5% dextrose in normal saline when plasma glucose is controlled to 200 milligram per deciliter. Then we have potassium. It is only when required, and bicarbonate also when there is acidosis. Then purpurium. During the purpurium, we have to give antibiotics to minimize infection. Breastfeeding is encouraged, and we have to be vigilant for the 48 hours for the baby that he or she does not have asphyxia or any congenital anomalies. We have to check their glucose level. It should not be less than 35. Otherwise, they will be hypoglycemic, and that can lead to fetal mortality. 1 milligram vitamin K intramuscularly routine. Then early breastfeeding should be done. This will minimize hypoglycemia and hyperbilirubinemia. So how many times? 3 to 4 hourly intervals. Okay, repeated at 3 to 4 hourly intervals. Now how we'll use the contraceptives? We can give low dose combined OCPs, oral pills, but they have a effect of vascular disease like thromboembolism and myocardial infarction. So we can also use progestin only pills. Okay, OCPs are also effective and they have minimal effect on carbohydrate metabolism, but due to vascular side effects they can be a problem. So we might also use progestin only pills, and IUCD is also used once the diabetes is well controlled. Thank you.